Hello friends, welcome to the next module of our course Space Gaining in Orthodontics, and the next module is extractions. So we have already discussed when to go for extractions and when should not we go for extractions, that is when should we employ the non-extraction method. So in short, whenever we want to move the teeth under better control and with increased ability, we go for extractions. Now, what all teeth can be extracted, which tooth should be extracted in which patient. So there are various factors which actually affect the choice of extraction. First one is treatment objectives. So what all objectives we have? Do I have to decrowd the teeth? Do I have to change the molar relationship? Do I need to change the profile of the patient? So all these objectives, they actually vary the choice of extraction. It's a type of malocclusion. For example, the patient is class 1. So in class 1, we never go for extraction in only one arch. We prefer to extract in both the arches. In class 2, the extraction pattern is either upper 4 or upper 4 and lower incisor. Or in growing patients, we sometimes also extract upper 4s and lower 5s. So with the type of malocclusion, the choice of extraction varies. In class 3 malocclusions, the choice is either lower premolars, lower 4s, or lower 4s and upper 5s. So type of malocclusion will definitely vary the teeth which need to be extracted. Aesthetics. So the patients who have got large chin button, the patients who have got prominent nose, in whom we cannot afford to worsen the patient's profile. So there we go for extraction of maybe the second premolars. Then is the growth pattern. Since in vertically growing patients, the musculature is very weak, so we have increased chances of anchorage loss. So we prefer to extract the first premolars rather than second premolars, because if we extract second premolars, the molars, they will just run into the extraction space and occupy all the space. So anchorage loss will be more in patients with vertical growers. Conditions of teeth. So definitely this also changes the extraction pattern sometimes. If the teeth, they are carious, they are heavily restored, they are impacted, then instead of extracting a sound tooth, sometimes we go for extraction of these particular teeth. Health of supporting tissues. Let's say we need to extract a first premolar, and in the same patient we have recession with respect to the second premolar. So definitely the periodontium is affected, and in that particular patient, we will prefer to extract the second premolar because the periodontium is not sound. Or maybe there is some periodontal radiolucency is there. So we will prefer to extract that particular tooth rather than extracting a sound tooth. Facial profile alteration. So this I have already mentioned. If we do not prefer to alter the profile, we go for extraction of 5s. If we want changes in the patient's face, then we prefer to extract 4s, that is the first premolars. So whenever we want to bring the change in the facial profile, whenever we want maxillary retraction of upper and lower anteriors, we go for extraction of first premolars. When we do not want much retraction, lesser retraction is required in lower face, then we go for extraction of upper 4s and lower 5s. So whenever minimal retraction is required in the anterior region, we go for extraction of the posterior tooth, that is the second premolar. And when less overall retraction is required, we might go for extraction of second premolars or even the first molars in few cases. And in patients with open bite, so in patients with open bite, since curve of Spee is leveled, or I must say it is flat, so we can go for extraction of 5 or 6. So as we'll extract the most distal tooth, it will help in accentuating the curve of Spee, which is required in an open bite patient. So removal of second premolars in mandibular arch is preferable for an open bite patient. This reduces the tendency of relapse and lingually inclined incisors, which are seen occasionally with extraction of first premolars. So what all are the indications for extractions of first premolars? In which all patients shall we go for extractions of first premolars? So the advantages these extractions have, since they erupt before any other posterior teeth after the first molar, they'll be readily extracted. They are strategically located close to the incisors. So as we all know, first premolars are located in between the anterior and the posterior segment. So if incisor crowding is there, if incisor retraction is required, definitely we require the space which is close to those teeth. And which are the teeth close to the incisors? Yes, they are the first premolars. So it is better to extract first premolars. The repetition of same center of each half of arch, that means they are in between the anterior and posterior crowding. Protraction of molars when it is not required, we definitely prefer to extract first premolars. And this gives adequate anchorage for retraction of 6 teeth. So as mentioned, since they are in between, they are in the center of the arch. So anteriorly we have 6 teeth, posteriorly we have 4 teeth. So this gives adequate anchorage for retraction of 6 teeth. However, if we extract the second premolars, definitely in the posterior segment, we are left with only the molars. So this does not give us the sufficient anchorage required. Then contact between the canine and second premolar is satisfactory. So what are the indications? So all the patients who have got convex profile with severe crowding, class 2 div 1 malocclusion with deep bite, class 1 with severe crowding, class 1 with bimax protrusion. So as a general rule, all the malocclusions which require space in the anterior region, there we will prefer to extract the first premolars. So this is a particular case, specific case for indication of first premolar. As you can see, there is a prominency in the anterior segment and we want retraction in the maxillary segment and the mandibular one. It is a bimax case. So where we will prefer to extract the first premolars. In extractions of second premolars, so according to Nance, whenever there is mild discrepancy, this avoids the distant face and less tendency for relapse, because the space attained will be in the posterior segment. So retraction would not be more and this avoids the distant face. According to Carey's analysis also, when the space requirement is 2.5 to 5 millimeter, then we can go for extraction of second premolars. So a patient with good profile, with mild crowding, in whom we do not want much retraction, only minimal space is required. Flat profile with moderate crowding, we do not want any retraction, but crowding is moderate, so we go for second premolar extraction. Class 2 division 1 on skeletal class 1, since the molar is in end-on or it is mild class 2, we have to protract the molar also as well as we have to retract. Mild class 3 interarch relationship plus mild crowding in upper arch. So since minimal space is required to retract and more of protraction is required to convert the molar relation, premolar extraction, second premolar extraction is indicated. Impacted, definitely when they are not favorable, they are impacted, we should go for extraction of second premolars. And grossly destructed or heavily restoration is there, we should go for extraction of second premolar. And the cases who present with abnormal root morphology, the roots are not favorable, so rather than extracting first premolars, there we can go for extraction of second premolars. And last but not the least, the patients with open bite. So as I mentioned, when we prefer to extract in this posterior region in patients with open bite, so the wedge, it tends to close. The wedge, it tends to open and it accentuates the curve of speed. So what are the advantages? Original facial contours are retained without the reduction of lip profile, since we are not retracting much in the anterior region, so the profile is maintained. Advantages of second premolar extraction, because the upper first premolar, it looks more aesthetic, so we should avoid its extraction. Lesser tendency for the extraction space to open in the lower arch. Less possibility of buccal or lingual furrow in extraction space. Easy correction of class 2 molar to class 1. So whenever we want the molar movement, we should prefer extracting the tooth which is closer to the molar, and that is the second premolar. And indications for first molar extractions, they are generally avoided because they do not provide us adequate space in the anterior region And also the adjacent teeth, that is the second premolar and second molar, they may tip in the extraction space. Also, this leads to deepening of bite and masticatory efficiency is impeded because they are the main teeth which help in masticatory function. So what are the indications? When they are carious, they cannot be restored, they are beyond restoration, we cannot preserve them. It is better to go for extraction of first molar. When they are RCT treated, so rather than extracting a sound, perfectly good premolar, we can go for extraction of first molar. When they are heavily restored, premature extraction of one side molar has been done. So in order to preserve symmetry in those cases, we can go for extraction of first molar. Facial considerations in the patients who have got large chin buttons and prominent nose, that is, we cannot go for retraction in that patient, but at the same time we need space, we want the molar relation correction, so we go for extraction of first molar. So rationale is, whenever we extract farther back in the oral cavity, that would help in preserving the facial profile, or there would be minimal facial change. In open bite cases, actually the first molars are extracted in patients with open bite. They are the good teeth to be extracted in patients with open bite in whom the contact is only in the posterior region. So when you particularly extract that particular tooth in which the contact is there, definitely it helps in closing of the wedge. Here I would also like to discuss the Wilkinson's extraction, which was given by Wilkinson in 1942. So at the age of 8.5 to 9.5 years, he advised the extraction of all first molars. What was the basis of these extractions? This gives us additional space for eruption of eights, crowding of lower arch is minimized, and the disadvantages are they give us limited space to relieve crowding. So adjacent teeth, they may rotate and tip into the space. So these are the disadvantages, and one should not actually go for extractions of first molar because they actually help in masticatory efficiency unless and until they are beyond restorations, they have bad prognosis, and they are not favorable for the anchorage. There are the second molar extraction indications. So whenever we want disimpaction of third molars, they help in faster eruption of the third molars, prevention of distin at the end of facial growth. So as mentioned earlier, whenever we extract farther in the oral cavity, that will help in preventing the distin appearance. Prevention of late incisor imbrication. Imbrication is the crowding. So late incisor crowding, what happens? That can be relieved with the help of second molar extraction. Facilitation of first molar dislication. In fact, few people, they prefer extracting second molars whenever they want to go for molar dislication because that eases the molar dislication. However, again, this is a controversial topic. Distal movement only is needed because to correct the overjet, so we extract the second molars. And then there are fewer residual spaces at the end of treatment because the space what we are gaining, that we are gaining in the posterior region. So at the end of treatment, that space can be again used by the third molar. Less likelihood of relapse. Good functional occlusion is achieved when we are extracting second molars, and good mandibular arch form is preserved. So indication, whenever they have bad prognosis, they cannot be restored. Mild to moderate discrepancy is there with the patients with good profile. Crowding in tuberosity area with the need for distal movement of first molar, there we can go for extraction of second molars. Third molars in favorable angulation of 15 to 30 degrees to the long axis of the first molar. Open bite cases. However, the disadvantages are too much tooth substance is removed in class 1 malocclusion with mild crowding. Location, it is far from area of concern. I require space in the anterior region and I am extracting a tooth in the posterior segment is not justified. No help in correction of anterior-posterior discrepancy without patient cooperation. Possible impaction of third molars even with second molar extraction. Third molars are extracted only to prevent lower anterior crowding and distal movement of 6 or 7 that actually creates impaction of 8. So in those cases, we can go for extraction of third molar. Also, the 8s are extracted before bilateral sagittal split osteotomy. So during this surgical procedure, actually the cuts what are made, they are made in the region of 8s. So it is always advisable to go for extraction of third molars 6 months before the surgical procedure. Then are the incisor extraction, or I can say the lower incisors, because the upper incisors are never extracted for orthodontic treatment. So indications are for mandibular incisors, whenever there is extreme crowding or extreme proclination or protrusion, gingival recession and loss of overlying bone on the labial surface, the teeth, they have fair to poor prognosis, mild class 3 cases with lower anterior crowding, in whom we want minimal retraction of the lower teeth, there we can go for incisor extraction. Whenever there are peg laterals in the upper arch or tooth size discrepancies there in the upper arch, to eliminate that discrepancy, to remove that voltage discrepancy, we can go for extraction of lower incisor. Advantages, they maintain or reduces the intercanine width, so helps in ensuring the stability. General arch form is maintained. Since we are not altering the mandibular arch form, this ensures the stability and minimizes the relapse problems. And because stability is ensured, so retention period is less, and anterior segments, they can be retracted readily if need be. So whenever we are gaining the space in the anterior region, in the incisor region, we can easily retract the anteriors. Immediate solid tooth support of entire buccal segment is there, because all the teeth, they are preserved in the posterior region. So adequate anchorage support is there. And this helps in easy reduction of overbite, also helps in intrusion and reshaping. As discussed in the earlier modules, intrusion, it requires space, and we are gaining the space in the anterior region. So this immediately or easily helps in the reduction of deep bite. Mechanotherapy is simplified, space closure is quick because the space is consolidated in the anterior region. So orthodontic treatment, it may include extraction of any tooth in the arch based on sound diagnosis and treatment objectives. But yes, you have to be very specific, very clear with your treatment objectives. You want facial changes, you want molar protraction, you want only retraction. The patient has good soft tissue support. The patient has incompetent types of lips or potentially competent lips. All the things should be exactly very clear to the doctor. Then only you can go for extractions of any tooth in the arch. Thank you. See you in the next module.